Okay, so it is 1 p.m. Eastern Time, 12 p.m. Central, so we will get started. Thank you all for joining us on our fifth and final CHAMPS Wednesday webinar in our Fall 2020 series. Today, we'll be hearing about frontline workers' nursing experiences during the pandemic and beyond. And we have 4 wonderful women's health hospital educators who will they pre-recorded their presentation, but they are also on the call to answer any questions after their presentation from NMMC Tupelo Women's Hospital. And then our very own Cheer Project Director, Laura Burnham, will be speaking about nursing focus groups that CHAMPS did and some findings from those. Before we begin, I'd just like to ask if everyone could mute themselves prior to the presentation so that we can hear the presentations clearly, and feel free to chat any questions you have into the chat box during the presentation so that you don't forget them. And you can also wait till after the presentation. We'll have time for Q&A. I also just we wanted to say, wish everyone a good Veterans Day. And if there are any veterans or active duty military on the call, thank you for your service, and if anyone in your family or your communities as well. Just wanted to say that, and thank you for joining us today. So just quick update on our Wednesday webinars. This is the last Wednesday webinar in our Fall 2020 series, but look out for information on our next Wednesday webinar series starting next January in 2021. Also, feel free to give us any ideas you would like for topics you would like covered. You can email us at champsbreastfeed@gmail.com. We're always looking for new topics and new ideas for things that you all would like to hear. And without further ado, I will click to the next slide and we will begin our presentation. It is pre-recorded. Thank you.
Welcome to North Mississippi Medical Center Women's Hospital. We are located in Tupelo, Mississippi. This presentation is about life at our hospital after the COVID hit. Your presenters will be the educators here at the hospital. From left to right is Charmaine Douglas. She's the educator for surgery. Myself, Renee Nichols. I'm in the NICU. Casey Peoples is in labor and delivery and the OB/ED. Kayla Reich in mother, baby, and the resource pool. We are located in Tupelo, Mississippi. We are part of the North Mississippi Medical Center Health System, which is a 640-bed regional referral center. But our hospital is freestanding from the main unit. It was opened in 1986. We have 15-bed labor and delivery rooms, an 8-bed OB emergency department, a 30-bed NICU level 3 unit, and an OB/GYN surgical service, and 36-bed mother-baby unit offering couplet care. As far as visitation goes, we're allowed to have, for a C-section mother, 1 person is allowed in the OR for spinal or epidural patients. No family is allowed in the waiting room. In labor and delivery and mother-baby, first was 1 support person that had to remain the same throughout the entire hospital stay. And now it's 1 person every 24 hours. In the NICU, we allow the mother and 1 support person for the entire hospital stay, and whether the support person is the father or someone else, that person cannot change. And unfortunately, we don't allow, before we allowed grandparents, and that's not allowed anymore, and it's just the mother and the support person. As far as short stay surgery and GYN, they have 1 visitor present just to drive them home. And something that we are fortunate in is that our mother-baby unit is on the 1st level. So we put the patient's room number on the windows so that the family can come to the outside of the window and they can see baby, they can see mama, and still be a part of it. So we're real fortunate to have that. So I will pass this on to Casey. Thank you.
My name is Casey Peoples. I'm the clinical nurse educator for labor and delivery in the OB emergency department. I'm going to start my portion with talking about personal protective equipment. In labor and delivery, our PPE requirements have evolved a lot over the past few months, but currently In labor and delivery, we wear our full PPE for all second stages of labor, pushing, and then also delivery. We do wear an N95 during our epidural procedures. Our nurses feel more comfortable with that, just with the close proximity that they do have to the patients. For our surgery patients requiring C-sections, we wear full PPE during surgery, and that is everybody involved in the surgical suite. So nurses, physicians, we do wear an N95 and gown and mask for those, and also a face shield. For our NICU staff, they wear the full PPE during C-sections for any positive or PUI patients that are in the NICU, and then also on all of the neonatal transports. The table that you see here with the PPE is used in labor and delivery outside of our rooms, just so that we have fast access to all of our PPE and we don't have to go back out to a supply room to obtain all that we need before our delivery, since we never know when we will need those. Early on in March, when we were doing planning for COVID, we realized that we did need a space for these patients to go. So our solution for that was to keep our antepartum patients on mother-baby to help this antepartum unit that we have available transform into our COVID unit. So that is what we have used for all of our PUI patients and our COVID positive patients that we have had. We have had to stock this unit and prepare it for any scenario, including an emergency department patient, antepartum, laboring patients, postpartum, because we have had patients labor, deliver, and recover on this unit. And we have also pre-opted a C-section down there. We do keep our well babies that were born to COVID or PUI moms on this unit, and we also have to prepare for a baby possibly being transported to our NICU, and then we have a designated room for our newborn follow-up clinic for our babies there. This little picture represents how we have our different zones on our unit, and that is just a visual for our nurses to know what PPE is appropriate in different areas of our unit. The red zone is where we do wear our full PPE inside of the rooms with the patient. And this also helps other hospital staff that is not working on the COVID unit to know which areas that they are safe to be in without having our COVID PPE on. I mentioned earlier that our hospital is a standalone women's hospital. Therefore, if we have any critically ill or compromised patients with COVID, we do send them to our main unit hospital that is just around the corner from our building. They do have a COVID unit that we can send them to if they need more interventions, if they become more critically ill. We have had one scenario where we have had a COVID patient that came to the women's hospital COVID unit, and she was just compromised, deciding. The OB physician determined that she did need to be sent to the main unit hospital for further treatment. So she was admitted to the main unit hospital COVID unit, where the intensivist physicians took over her care there, and our OB nurses did go over there to do fetal monitoring and anything else that she needed. She did end up with a C-section. So we had our staff go to our main unit hospital to perform that C-section. We have a very good working relationship with our staff at our main unit, and they were very helpful and just eager to help us do whatever we needed, and very willing to let us take over the OB portion of her care for sure. I'm going to turn it over to our next speaker.
Hi, I'm Kayla Reich. I'm the clinical educator for our Women's Hospital Mother-Baby Unit and our resource pool. So as you can see on this slide, if I heard this saying once, I heard it a million times. This is a fluid situation. So COVID has been ever-changing, constantly evolving. So I'm going to talk to you a little about our early days and how we have adapted some of our care as guidelines have been updated. So we actually started out not allowing anyone to wear masks. We had a few bedside staff when COVID was first being talked about in the United States that were bringing masks from home or that they had made themselves, and so we actually discouraged them from wearing those before we knew the updated guidelines and recommendations that everyone should be masking. So once we found that out, our hospital mandated for all clinical bedside staff to wear masks. So the hospital provided us with masks for us to wear in any patient interactions, but at that time we still didn't have non-clinical and office staff masking. Well, now all employees, patients, and visitors are to wear a mask at all times when they cannot be socially distanced at least 6 feet from each other. We also now wear full PPE, as Casey spoke to, in all deliveries, both vaginal and cesarean sections. And what our full PPE includes at our hospital is an N95 mask covered by a procedure mask, and we do this to prolong the use of our N95s. We then wear either a face shield or goggles. Most of our nurses prefer the face shields. The goggles tend to fog up and be much hotter and more difficult to wear for long periods of time. And then we wear a gown. We did have disposable gowns, and due to a shortage of those, we now have reusable cloth gowns that we launder ourselves. And those are also worn for the second stage of labor during pushing, just because of the high risk of aerosolization. And we had an occurrence where a patient developed a fever after delivery. The nurse that had assisted with her epidural placement had been right in her face without an N95 on, and so just for everyone's comfort, we also decided that N95s are now going to be worn by nursing during epidural placements. So during the early days, a lot of our activities at the hospital were postponed. We canceled our annual reviews, meetings, projects were put on hold. The only thing anyone thought about was COVID. People were quarantined for up to 14 days if they were just known to be exposed to someone that was COVID positive in the very beginning. We did have some staff members that became COVID positive that had exposed other staff members. This was prior to the masking of all staff. So now all of our areas have been measured, and we have a maximum capacity allowed by the hospital. This includes our charting areas, our break rooms, our educational rooms. So we are getting back to some of our activities, but we are still limiting how many people can be in a room together. And even for our annual reviews, we made them much shorter this year, fewer people at a time, just to try and limit our proximity. So separation versus rooming in was a huge discussion when we were first talking about COVID and opening our COVID unit and having deliveries and taking care of patients. So at first, we actually were going to encourage separation of mom and baby, no matter if she was asymptomatic or only mildly sick, and we were not going to allow any visitors on the COVID unit. And we modeled that off of our main unit, COVID unit, and they still to this day do not allow visitors on their COVID unit unless it is an end-of-life situation. Once the CDC updated guidelines, and after thinking of all the negatives and positives, we decided to allow a physician and patient-based decision making. So if someone only has mild symptoms while they are laboring and postpartum, we allow them to have one support person. That support person cannot change throughout their stay, and that person does not leave the mother's room. So we provide all of their meals and everything that they need while they are here. But we have found that offers mom better support, more help with the baby, more educational opportunities and learning, and they're a lot more confident knowing how to take care of their baby and maintain a safe distance with COVID than if they had been separated while they were here. So we've only had one mother who chose separation of her baby, and it was in the very, very early days, even before the CDC updated their guidelines. Since then, all of our babies that have been born have roomed in with their mothers. We do keep them in an isolette and try to distance 6 feet away. Anytime the baby is out of the isolette, we have mom and the caregiver mask. And so far, all of our babies we have tested at 24 and 48 hours, and none have been COVID positive. So we have had some positives come from this whole COVID situation. For instance, our physicians have section meetings monthly where they discuss patient care, order sets, changes in practice. And since we've started doing those over the phone and virtually, we've had our highest attendance ever. Our hospital normally does a baby fair every year in August, and we have vendors come and educational opportunities, and pregnant women or their families come and tour our hospital. Well, we could not do that this year, so we took our baby fair virtual, and we had a virtual baby week at the end of August, and we had physicians participate and make recordings on infant care. We did virtual tours of our units, and these are still posted on our website today for people to view. We had very high participation, and some of these videos were viewed up into the thousands of times, so many more people than could have ever come in person. We've heard from most of our patients that they enjoy having less visitors. It gives them more time to learn their baby and get to know each other. Our NICU parents are not having to share their time with anyone else or any extended family. Our nurses are enjoying this restricted visitation. Patient care is easier for them, and I have had several ask if visitation restrictions end in the future, could we limit visitation after deliveries for a certain length of time to recover the patients. And we have definitely been expanding our communication and our learning experiences. We're learning how to record, do things virtually. During our annual reviews, we made them much shorter this year, a lot more hands-on. We just did drill after drill after drill instead of doing PowerPoints and tests, and we got some really good feedback, and staff really seemed to enjoy a lot of that, and they have seemed to enjoy a lot of the virtual communication and not having to attend so many in-person meetings and things. So there are positives to COVID, and now I'm going to turn it over to our next speaker.
Hello, my name is Charmaine Douglas. I'm the clinical nurse educator for surgery department here at our hospital. Testing. Employees are not routinely tested. All employees are required to wear a mask when in the building. Before clocking in, employees are required to check temperature, and by clocking in, employees attest that he or she is well and are without any COVID-19 symptoms. Universal screening is performed with every patient upon admission. There are specific questions asked, and their answer determines what action is taken, if any. The questions have changed from when COVID-19 first began, as more information has been gathered about the virus and how it spreads. This is also the case for visitors coming into the hospital. Their temperature is checked on arrival to the hospital, and questions are asked before they enter the facility. At this moment, some complications being COVID patients are being readmitted with pre-E symptoms. Surrounding hospitals are universally testing, whereas we are not, and this has affected our hospital when those patients are transferred to us and are asymptomatic positive cases. And then also several patients have developed symptoms after delivery, and this is why we take those precaution measures with laboring patients and C-section patients to already have the necessary equipment on just in case they come up positive after delivery. In surgery, we are currently, all patients having a laparoscopic surgery done have to be tested for COVID-19. Examples being robotic hysterectomies or any type of robotic surgeries and laparoscopic tubal ligation. During C-section, staff is required to have on full PPE, being the reusable gowns right now, hat, N95 with surgical mask over it, eye protection, and shoe covers. Due to studies showing, and the case that we have had cases that pregnant women may not show symptoms until after delivery. An N95 mask is required in all laparoscopic cases due to the high aerosolization, and it is recommended in any other surgical case when assisting with intubation and extubation. And this is all staff within the room: CRNAs, surgical techs, the physician, circulators, and even students. Patients are masked when transported to and from surgery. Once the patient is deemed stable and awake enough, she is masked in recovery before being transported out to her room. Here we have pictured every year Pastoral Care comes around to the nursing units to bless hands. This year was different, being that they could not touch our hands, but this is an example of one way we adapted to the circumstances. COVID-19 has brought about many changes to our facility. We have all had to work together and adapt to these necessary changes for the safety of our patients and staff. It has definitely been a learning process that has required us to be flexible and willing to adapt to the changes. It hasn't been easy or without challenges, but we have pulled together as a team and have worked through these challenges and are continuing to do so. Thank you.
Great. So we will pause there for a moment to see if anyone has any questions. I'm checking the chat and I don't see anyone who's chatted in questions yet, but thank you all so much for presenting. That was such a great presentation. Does anyone have anything that they like to ask, or if the women's hospital educators, if you have anything you want to add at this time, you can unmute yourself, put yourself on video.
Hey, I don't think we have anything else to add, but we are open to answering any questions that anyone else has.
Thank you. Well, I guess I'll ask a question. One question I had is just like, were there any experiences in particular, or stories that any of you can share? You shared a couple during the presentation, but any stories that you think will stick with you in terms of kind of how you support mothers and infants during these especially difficult times, and how you were able to evolve your practice and continue to support mothers and infants so successfully during this time?
I think one of the situations that sticks out to us the most is the one that we touched on a little bit. That was our most critically ill patient that we've taken care of, and we really had to work with a lot of other units and team members to facilitate her care. Her baby did go to the NICU, so we weren't able to facilitate rooming in with her. But I think that was just a really good example of how we all work together very well, our hospital as well as the main unit hospital, to provide the best care that we could to her.
Great. And I see one question in the chat that I'll share with you, which was, have you experienced a higher percentage of inductions since COVID-19?
I don't think so. I haven't noticed our induction rate being any higher. No, ma'am, I thought you had something new that we hadn't heard about with weight induction, so it's going to let you explain that. But no, our induction rate has not changed.
Great. And I have one more question, if I'm as the moderator. One question I have is just, it seems like there were a lot of changes, like let's say with the mask, that at first no one had mask, and then surgical mask, and then N95, and kind of how that felt for you all going through those changes, and if there was kind of fear or uncertainty there about what the right thing was. Not that there was a right thing at any specific time, but just how you all felt in those circumstances and situations.
Sure. I I think every day was nothing but uncertainty at the beginning. And I mean, with something so new and so few guidelines, I feel like we all work together as a team, and we're thankful to have such a great team here at our facility. And we kind of would split up the information. We were reading every day to see what new information had come out, and really working with each other and our physicians. And it was just constantly changing and updating and questioning, are we doing the right thing? Are we thinking of everything? So now that we've had some COVID positive patients that we've actually taken care of, we definitely feel a lot more confident that we're doing the right things.
That all makes sense. And I think it's really telling that, the four of you were able to put together this presentation together, and it just seems very emblematic of the collaboration that happened at your facility. And thank you so much for sharing with us.
Thank y'all for giving us the opportunity to do so.
Thank you.
And if anyone thinks of any other questions, feel free to put them in the chat and we can continue after. So I think now I will hand it over to Laura Burnham, who will be discussing our CHAMPS nursing focus groups.
Great, thanks, Maytal. So I'm going to be sharing with you all another presentation about nursing perspectives in maternity care, but my presentation is going to focus on kind of pre-COVID experiences and kind of those nurses' experiences with the Baby-Friendly Hospital Initiative before COVID kind of came onto the scene. So next slide, please. Awesome. So as you all know, much of the Baby-Friendly Hospital Initiative work is led by nurses, and it's dependent on nurses' adaptation. But little is known about nurses' perspectives about BFHI in kind of the medical literature. So we wanted to share that 97% of Mississippi CHAMPS hospitals have baby-friendly task forces that are led by nurses. And then since 2014, 22 hospitals in Mississippi have been baby-friendly designated, and much can be learned from their experiences. Next slide. So CHAMPS decided to conduct focus groups of nursing staff in baby-friendly designated Mississippi CHAMPS hospitals. And the objective of these focus groups was to describe obstetric and postpartum nursing staff's experience becoming baby-friendly, including the perceived barriers and facilitators to designation. And so we analyzed those data using a thematic analysis approach. And you can see in the figure below kind of the process of a thematic analysis. So there are 6 phases. The first is familiarizing yourself with the data. So really we read through all of the transcripts from the focus groups. Generating initial codes. So then it's when you're reading through those transcripts, kind of organizing them into different buckets or different codes. The next phase is searching for themes. So kind of organizing those codes into different themes, reviewing those themes, and then finally defining and naming the themes. And then summarizing the results is the final phase. And that's really when we wrote up this paper. Next slide. So the results from these focus groups were that we did 5 focus groups total, which included 22 nurses. And then 5 main themes were identified. They're listed here, and I'm going to go through each of these themes on the next few slides. So next slide, please. So in terms of the kind of hospital and nurse demographics from the hospitals where we did the focus groups and the nurses that we interviewed. So 3 of the hospitals were in rural areas of Mississippi. 2 of them were in metro areas. On average, the number of months that the hospitals had been designated for were 12 months. And then the average number of births for the hospitals was 1,144 annual births. For the nurses that we interviewed 8 of them were in labor and delivery roles, and then 14 of them were in kind of mother-baby NICU roles. Next slide. So for the first theme, which was the change required for BFHI was hard. Nurses really described a variety of psychological, practical, and logistical factors that made BFHI implementation hard for them. Those included resistance to the idea of change, which was kind of a psychological factor, logistical challenges in the hospital, monetary barriers, actual kind of physical barriers in the hospital, and then different staffing challenges. Next slide. So an example of a psychological challenge, there's a quote from this nurse, and it says, "And it is a change for the nurses. You know, nurses are very structured and they have their own way of doing things. And when you put a little dent in that, they have to reroute everything." And then an example of a nurse talking about a practical challenge is when one nurse said, "For us in the nursery, they're saying you're going to do your assessments in the room and stuff. We needed to have baby blood pressures. We had to have ways to do oxygen saturations on our babies. So having the equipment that we needed was a big deal." So hopefully, I think for some of the nurses on this call, that might sound familiar to those quotes. Next slide. So the second theme was that nurses felt empowered taking a leadership role in the adoption of BFHI. So nurses felt like they pushed their facility to adopt BFHI practices, which was an empowering experience for them. Some common experiences were standing up to resistant parties, taking ownership or leadership of the BFHI work, and a sense of pride after BabyFriendly Designation. So at one point, the interviewer asked, "And what do you think it took to make physicians okay with the process now?" One nurse said, "We just didn't do it." And the second nurse answered, "Yeah, nurses with backbone." Next slide. And then I also want to share with you all this quote that kind of typifies theme 2. So, "If people are beginning this designation process, it is almost overwhelming. The big picture of it is overwhelming. For us, we work together real well. We're cohesive. And I think the director is good at delegating and allowing certain ones of us to take on a specific part of it. And that helped our department on it. You cannot do it by yourself. You can't do it with just a couple people. It takes everybody. Well, it takes a bigger group, and it takes people owning a certain part of it, I think." Next slide. So the third theme that we identified through our focus groups was that nurses felt challenged by the unintended consequences of BFHI. So nurses often express concern regarding certain unintended consequences of BFHI implementation, which included some ongoing safety concerns. So nurses, even after BabyFriendly was implemented, they still were concerned about risks of infants falling during rooming in. So while moms had them in the room, especially at night. Nurses were also concerned about increased rates of hypoglycemia with reduced formula supplementation, and also emergency situations during initial skin to skin. So there was some concern that, something might go wrong with mom or baby during initial skin to skin, and they weren't sure, how they might handle that. Nurses also expressed a fear of patient dissatisfaction with BFHI practices. So a lot of the time this was around patients feeling frustrated with a change in practice, like rooming in at night. So they were worried that, moms would be mad when they told them that there wasn't a nursery for them to take their baby to at night. And they encouraged them to keep their baby. They also expressed a fear in patient shaming. So nurses they really didn't want to make patients feel bad for the choices that they made. And most commonly, this was around rooming in and breastfeeding. So nurses were worried that if they encouraged moms to room in, or if they were encouraging moms to breastfeed, that moms would feel ashamed if they chose not to do those things. Next slide. So an example, a quote about an ongoing safety concern is, I don't think the concern of dropping babies is totally gone. I'm still concerned about that, especially if she is on medication. And we heard that kind of a similar quotes from a lot of different nurses about that. A quote that was about fear of patient shaming was, that's my only critique of it, is I do feel like it's brought a sense of shame to those that maybe have tried to breastfeed in the past and weren't successful, and they just don't think they can do it again. So nurses, you know, they were just really concerned. They didn't want to make their patients feel bad. Next slide. Okay, so theme 4 was the theme that patient education was pivotal to the implementation of BFHI. So nurses really felt that patient education was essential to successful BFHI implementation. And some common beliefs around this theme was that prenatal education prepares patients to receive BFHI care. So a lot of nurses talked about how essential prenatal education was before they even arrived at the hospital. Another belief was that BFHI improves the quality and extent of in-hospital education. So nurses really felt that they were giving better education to their patients once they had implemented baby-friendly practices. And then the last belief was that community members spread information about new BFHI practices. So some of the patient education the nurses talked about was actually occurring through the community. So as the community learned about practices like skin to skin and rooming in, they were sharing it with mothers before they even came into the hospital to give birth. Next slide. So one quote that kind of typifies this theme is, I feel like with the skin to skin and the education that all the nurses have gotten about the breastfeeding, the patients are in such a better place. I mean, they just get so much more information and education from every different nurse they come in contact with because of BabyFriendly. And they have more people helping them to be successful, and that's just going to make them be more successful. I've seen a huge difference in the patients. Next slide. Okay, so for the final theme, it was that nurses' attitudes changed from negative to positive over the course of adoption. So nurses really described how their initial negative reactions to BFHI shifted to positive feelings after successfully implementing the practices. For example, one nurse said, a lot of people thought it was like somebody else coming in from outside saying, this is how you're going to do things now. And lots of times people resent things like that. I think it turned out real well, but just the initial, I don't know about this. Who are you to tell us what to do? This is the way we've always done it. But I think it's worked out well. Next slide. And finally, kind of the last quote to kind of talk about these focus groups is just one nurse said, it wasn't easy, but was it worth it? Absolutely. That kind of typifies the nurse's description about what the baby-friendly process was like. Next slide. So in conclusion, nurses really shared similar experiences and cited common facilitators and barriers to baby-friendly designation. Nurses described the overall process of baby-friendly designation as challenging but worthwhile. In terms of kind of future directions and how to use these, the results from the study, are that hospitals seeking designation can learn from these experiences to make their journeys easier. And that's my last slide. Next slide, I don't think there is. Fine. Okay, just my question slide. So we'll open things up now for questions from the group, either about the nursing focus group study I just presented on, or if you've thought of another question for North Mississippi Medical Center, you can ask that question now. Well, Linda, thank you. So Linda wanted to just share that she's so proud of all the hospital nurses who work so hard to gain baby-friendly designation. And she wants to thank everyone. I agree. People should be very proud of their hard work. And really the reason that we did interview nurses too was because this work was nursing led in so many of the hospitals. So, nurses should just feel really proud of their work. All right. Well, I guess we don't have a very talkative group. Okay. I don't know. Maytal, did anyone send you any questions?
No questions.
Okay.
That I can see, but thank you all, and thank you to everyone who presented on the call today. And just to share that this is our last webinar in our Fall 2020 series, but we will begin again in January 2021. And if you missed any of the webinars from the past weeks, they are all available on our website and also on our series flyer that's updated after each webinar. So thank you so much for joining. Oh, we have one. Oh, Linda has chatted in. Also, please remember that La Leche League leaders are still here to support families. And in Esville,
I think it's Starkville.
Starkville, thank you. We are holding Zoom monthly meetings. So that's great to know as well. And yeah, just thank you to everyone who is helping support mothers and infants in these challenging times. And again, have a good Veterans Day, and thank you for anyone in your family and community or yourself for any service. Thank you so much and have a great day.
Thanks, everyone.